and welcome to Wimpole Street Dental Clinic. My name is Chris Jamel, and in the following video we would like to show you how we place immediate implants in our clinics and how we can solve extremely difficult cases and highly aesthetic cases with immediate implants and gum grafts and soft tissue grafts. Thank you very much for your time, and we really hope that you enjoy the video.
With the help, of course, of great staff, I hope that we have now reached a level which is able to recreate the anatomy, the function and the aesthetics of failing teeth within a single day. Of course, we need to prepare properly and take proper diagnostic records, but this lecture is my signature lecture, and I hope that I can show you that immediate implants are actually now not something extraordinarily new or something very experimental, but should slowly become state of the art. An immediate implant is nothing else but to extract the tooth, the broken tooth or the infected tooth, place an implant, augment the bone, augment the gums, and place a new temporary tooth on the same day. Let's dive into it. When a patient visits us, normally what they want, firstly, they always say, or very often say, I would consider an implant to replace the tooth, but what they really want is actually the tooth, the white bit which you can see sticking out of your gums. So when they say they want an implant, I can only imagine that they don't actually want the metal or the ceramic screw inside the bone, but the tooth on top. In the usual treatment, we, 20, 30 years ago, what we did mostly when we had an infected or broken tooth, we extracted the tooth and waited between 3 and 6 months, sometimes even a year, depending on the size of the infection. Then we placed the implant and needed again to wait sometimes 3 up to 6, in the worst cases sometimes even 12 months until the implant was healed into the bone and had a fixed connection with the bone. Then in some cases, some dentists, including myself, place a temporary just to reshape the gums very nicely, and then the final restoration takes another month. So the overall time needed from tooth broken and having an extraction to you having actually a tooth again, a white aesthetic and functional tooth again, is between 6 and 12 months, sometimes even 1.5 to 2 years. So I do believe that this, in the modern time, is just not good enough. When you go to an ophthalmologist, you get your cataract replaced within 50 minutes, you get a new lens within 50 minutes. When you have a hip replaced, you can walk normally after the operation. And medicine is evolving more and more into single-stage surgeries because we just can predict biology and healing patterns so much better. What is important, and this is actually the culmination of almost 20 years of research and practical experience in the clinic with a few thousand placed implants, and among them many, many immediate implants, we need to understand the biology and we need to understand the changes in technology, which now enable us to achieve predictable, reliable outcomes. So we know exactly before we actually start any operation, we know exactly where we will end up in 10, 15 years. So I just want to show you how that is possible. First of all, the key to all our treatments always is the biology. We have to understand how the human body reacts to inflammation, how it reacts to trauma, how it reacts to implant placement, how it reacts to gum grafts or bone augmentation, and what the healing patterns are. And of course, we do need to understand the interaction of an implant with the host bone and the host tissue. So this is an implant from my own research, in this case an animal trial in mini pigs, and a fluorescence microscopy. That means the lighting area just shows you indirectly how the bone always evolves around the implant, that the implant actually becomes a living part almost of your body, and your body interacts with it. So it puts bone around the implant, maybe as an immune reaction. That is the newest theories, but the bone stabilizes the implant. And if you chew on it over time, if you don't overload it, the implant actually gets stuck to the bone much more. On the right side, it's a bit technical now, you can see a part of an implant, the so-called implant abutment, plus a crown on top. We here, L is the abutment, I is the implant shoulder, IS, implant shoulder, I is the implant, ST is the soft tissue, in this case the biological width consisting of the connective tissue and the junctional epithelium. And this is a classic attachment structure of an implant, the abutment and the crown, and a classic reaction with the surrounding tissues. So you can see the implant integrates very, very well with the surrounding tissues. What does the science say? And immediate implants is not something new. So you can see the small print in the bottom. These are a few publications. Of course, there are many, many more, which I have summarized for you here. What do you actually know? Implants or immediate implants are placed already since the 1970s. So it's not something new. And the implant survival rate is 95 to 97%, depending on the studies we cite. And for delayed implants, it's 1 or 2% more. So the immediate implants have 1% larger failure rate. So, but you see, that's very, very comparable. The bone remodeling happens with or without the implantation 4 to 12 weeks after the extraction. So even if you remove the tooth and you place an implant, or you remove the tooth and you do not place an implant, the same bone remodeling happens. The infections around implants do not play a role. I've been asked that many, many times, but my tooth is infected. Why do you still place the implant in the same day? The reason for the infection, in most cases, is not the infection. The reason for the infection is a broken tooth or the tooth itself. So if you remove the tooth, you remove the reason for the infection. Of course, you need to remove the infectious tissue and clean up. And of course, you have antibiotic coverage around the operation, and probably for a week, in some cases 2 weeks later. But the infections themselves do not play a role. We have to clean properly, but the infections do not play a role. The thickness of the buccal bone plays an important role, and it reduces in most cases by 50%. So that's something we have to estimate for and place our implants a little bit more lingually or palatally, respectively. The gap between the implant and the extraction socket should be filled when it's larger than 1.5 millimeters. I always fill my gaps regardless, because as you can imagine, the implant itself in most cases is round, and the diameter of the tooth and the shape of the emergence of the tooth is not round. It's kidney shaped, it's triangular shape, it's trapezoid, it's triangular, and so on. So the implant has always a different shape. When you remove the tooth, there's always this tiny gap between the previous emergence of the tooth and the round implant. The vertical changes, and that's very important for the aesthetic results, are important and dependent on the thickness of the buccal bone. That means the bone which is facing either the lip or the cheek. And in most cases, well, I recommend my patients as well, a temporary keeps the bone and the soft tissue much better than a prefabricated, industrial fabricated healing abutment, a healing cap. And that's something very important. I see it sometimes being done very, very wrongly, either too superficially placed or too deeply placed. The implant shoulder should be around 2 to 3 millimeters below the expected top line of the gum. This is so-called comfort zone. If you place it too high, you can have recessions or see the actual implant shoulder. If you place it too low, you equally have recessions or can have recessions if bacteria can get between the implant abutment and the actual implant. And ideally, that was the case, that what the science says, the buccal lamella, the buccal bone, should be intact. But this is something I'll come to in a second, because that's not entirely true. What do we know about the soft tissue, the gums? What does the science say here? 3 years after the placement of the final restoration, we always have around 1 millimeter loss. So when we place your final restoration over the course of the next 2-3 years, you will roughly lose 1 millimeter of gums, regardless what you do. The recession risk, and that's something extremely important, is only 17% when we position the implant a little bit more to the roof of your mouth, to the palate, or towards the tongue, but increases to 60% when we place the implant too far buccally, too far out towards your lips or to your cheeks. And this is now something relatively modern, come out in the last 2-3 years, that there's a symbiotic relationship between the soft tissue, that means your gums, and the hard tissue, that means your bone. That means we need ideally 2, better 3 millimeters of gums protecting the bone from any recession or bone loss. And as said is already, for the bone, that an immediate temporary keeps the anatomy and the volume of the soft tissue much better than an industrially prefabricated healing abutment. Now we come to the problem of the bone which is facing the lips or the cheeks, which is called the buccal lamella. That means when you remove the tooth, there's a very thin layer of bone, and this thin layer of bone is extremely important to prevent any aesthetical failure. So what we did, the usual consensus was, if this buccal lamella is missing, you cannot place the implant, you have to wait. And I challenged that with an animal trial. This is the forefront of a mini pig, where we did bone augmentations directly on the frontal bone, and this is so one-walled defect, as we call it. So there's not many bone walls. It's a bit technical term in this case. And we just checked what happens. And you can see here the yellow rectangle shows the area of the bone. You can see the black thing is the artificial bovine origin bone. You can see below the tiny, I'm not sure if I can use the mouse, I maybe can, below this line here, you can see that there's a tiny bit the original host bone, and between the artificial bone, this here, that's actually new built bone. And on the top you can see the membrane, which you've seen in the previous picture here. This is the membrane. So if we go further, you can see here in the fluorescence microscopy, that means we give the animals tetracycline and other fluorescent dyes, which then go to the so-called osteoclasts. That means these are cells which are eating away at the bone. So we indirectly can improve bone growth. And you can see the areas, show it again with the mouse, this is actually completely refreshed new bone. And you can see the connection between the old bone, not much is happening at the old frontal bone, but here in the new area, which we augmented with bovine bone, you can see a lot of things happening. So that means we can create new bone if we just have one wall defect, which is absolutely fantastic news. So this study results were very clear. There's no statistically significant differences whether we have the peristeum, whether you have big pars granules or small granules, whether you have at original bone or not. The difference were just merely 10%. So whatever we do, or almost whatever we do, everything with the bone can grow, as long as of course, as we have sterility and no bacteria and no inflammation. The best combination for bone growth was small particles of the bovine bone in this case, added bone, that means bone from the bovine origin and mixed with your own bone, and a membrane and a peristeum. So that's the ideal scenario. This is the publication. So yes, we can rebuild bone on a single wall defect. That means the importance of the buccal lamella is not that given anymore. we can place immediate implants although the buccal lamella is missing, although we have inflammations. One case, I would always be a bit more careful if you have a periodontal disease and smokers or a combination of both. Then firstly, of course, stop smoking, and the second is the periodontal disease needs to be treated completely. And the other thing is, if patients have chronic pain, then I would be careful and try to find a reason for the chronic pain first before we place any implants. So if there's anything completely unusual, then refrain from placing immediate implants. But if it's just regular periodontitis or a regular periapical infection of a failed root canal treatment or a crack or whatever it is, you can go ahead with the immediate implant, but of course you need to augment and you need to have a sufficient amount of soft tissue. Let's prove that to you. This is one case where a young lady fell from her bicycle when she was 12, and of course she came back a few years later with infections at the tip of the teeth, and because of her age then, she was 22, we thought it best to try to keep the teeth. You can see here the x-ray, and I tried to show you with the mouse the inflammations here, and here's a large inflammation here. And of course we tried to keep the teeth initially with root canal treatments, and because she was so young, and we managed for a year, and you can see the left side actually doesn't look too bad, but the right side here, unfortunately, you can see an inflammation again, so the teeth were lost. So this inflammation here, unfortunately, persisted. So after the diagnostic records, that means three-dimensional x-ray and so on, I went into the operation. Unfortunately, I was a bit more arrogant at the time than I hopefully now. I promised her she would walk home with fixed teeth, and I didn't prepare a denture. So you can see here there's next to no bone anymore. All the bone is gone because of the inflammation. So what we decided to do, yes, we made a promise, and I intended to keep that promise. So we placed the implants. We did a massive bone augmentation and added additional gums and placed temporaries on the same day with only one wall of bone. So you can see I haven't taken many pictures in the operation because I was quite nervous. That's 15 years ago, but it worked well, as I can prove now. You can see these are the crowns, and that's the situation 4 months after the implant placement. You can still see a tiny bit of tissue, scar tissue from the incisions, and these are then the final crowns. I would solve that differently now because I would know that the implants are no problem anymore. At the time I combined both crowns just for more stability. This is not needed anymore. We have more data now, and but at the time that was just a personal decision for me, just to be sure. You can see here these are the implants. And massive tissue here. I hope you can see my mouse. Massive tissue here in the front. The implants here. The actual titanium screws. The white bits is the bone augmentation material. There's no inflammation around that. You can take it out. You can leave it in. It doesn't really matter. And you can see this thickness here. This is our resorption layer for the next 10-15 years. Good, this is the view then en face, and that's then ready for placement, and that's the situation then placed. So like I said, I wouldn't join the crowns today anymore, but at the time I was careful. Here's the proof of the x-ray. You can see all the inflammations are gone. You can see just the rest of the artificial bovine bone. And here you can see on the left side, that's the placement, and that's a recall after 4 years. And you can see here, if you check the gums, I could even have gone further down. So that is an absolute stable and beautiful situation, completely unchanged. The patient brushes extremely well, and yeah, just a very stable situation. And the implants have worked well. The aesthetics have not changed at all towards the beginning. And here's another case from a tooth on the side. Patient came with a broken tooth. We do our original diagnostics, which we always do. That's the three-dimensional x-ray. That's a digital scan. Then we prepare an implant guide and go into the surgery. This is the final restoration. Then after implant placement, scan and the restoration. The patient complained about this problem with his sinus. If it's probably asked if this could be probably related to the implant, it wasn't. And you can see here, this is your implant, and you can see what I wanted to prove. You can see there was a massive inflammation here at the outside in the beginning. Well, here on the top, because the tooth was cracked, inflammation, we augmented that with bovine bone and a gum graft. And you can see the implant here, and you can see perfect new bone. So we can place immediate implants although we have large inflammations. You can see here again, just to prove, large new bone, absolute stable implant right in the center, and this should be a situation stable for a long time. So what has changed in technology enabling us to do these things? The first thing is, of course, we can take now really precise three-dimensional x-rays with a relatively low radiation. Just for comparison, it's around 10 to 15 days, depending on the area in the United Kingdom where you live, comparable with the background radiation. So a CBCT or three-dimensional x-ray does not have that much radiation. And of course, we can take now three-dimensional digital scans instead of the old rubber impressions, and we can combine those and plan our operation before we actually start the operation. So we know exactly where the anatomical important structures are, we know exactly where the neighboring teeth are, we know the color, and we can produce the temporaries before, so we're perfectly prepared for every operation. And that makes the whole operation predictable, and that's exactly what we want in medicine. We want to have predictable results. We want always to have the same result when we do the same treatment. Here, just some evidence, not studies from myself, some studies that guided implantology is, of course, much more precise than manual implantology. I was always myself very much convinced that I would be manually much better than guided, but we're nowhere near. Now, if you're interested, you can read that paper. So guided implantology is much more precise than manual implantology. And the second thing is the guided implantology is, of course, much more efficient. So dentists should have, or surgeons or dentists should have an interest to do guided surgery for the very simple reason that if you prepare yourself before the operation, you actually know you have so much more information. You know the anatomy, you know where the structures are, you know where the teeth are, you know your implant length, you know your diameter and everything. So the nurse can prepare a perfect operation. Everything is so much easier, and it shortens the operational duration. So the key to the success is that we know our software. I show you one of the most difficult matchings, that is the edentulous jaw. So what you can do, just for an example, you can place small mini screws. You can see them here on the CBCT 1, 2, 3, and here on the scan 1, 2, 3. So you have, in this case, this program needs 3 points to match the scans. You can see here them extrapolated, and then suddenly you have a perfect match between the X-ray, the three-dimensional X-ray, and the model. And then on that model, very simple, so here's the model matched with the CBCT. You can place your wax up, and now the planning is so easy. You see the bone, you see where the teeth will be in the future, or should be in the future, so you can place your implant directly below the teeth. So you have prosthetically, that means with your restoration bridge, whatever it is, single crown, full arch, you have zero problems anymore, because everything is perfect just because of your planning. So you can see here an all-in-4 planning in the upper jaw, so everything becomes very, very predictable. The technician can prepare, we can prepare, the operations become much smaller and short. Instead of 6 hours, we can boil down the operations now to 2.5 hours for 6 to 8 implants in the upper jaw. It makes it just so much more predictable. Here you can see the implant sleeves. This is where the special burrs go through for the for the implant positions. And this is then the produced guide, which we can very simply place it on the upper jaw. They always fit absolutely perfectly and can drill for the implant positions, and we're absolutely sure we're in the right position. Here's just a proof that guided implantology really works. You can see here in the top jaw, this is our planning, and the lower jaw, that's the actually panoramic X-ray after the implant placement. So you can see, just check the relation to the neighboring teeth, absolutely perfect. Or here, this is your upper left sinus, the maxillary sinus, and you can see how perfect we are with the planning. So this is something you cannot achieve with manual implantology. Or here, a much more difficult case, we removed implants teeth the same day and placed new implants on the same day. You can see how accurate the planning was and what we achieved with the extra implant placement. This is one operation, 1 day, 6 hours. Removed all the inflammation. You can see on the left massive inflammations, but it doesn't matter. We can do the sinus lift, so we can do the bone augmentation, everything in one go, and it still works. No? We just clear the inflammation, remove the teeth, clear the inflammation, place the new implants, and it works just perfectly. But I'll show you in a few cases, I think it's 2 cases to come, what we actually can do. So this is a patient with a wonderful looking front tooth. The problem is, if we have a look at the 3-dimensional x-ray, we can see here a massive hole in the back. That's called an external resorption of this front tooth. So this front tooth, of course, you can try to do a root canal treatment and a filling, but we decided for a more predictable option, so that is in case is an immediate implant. So here you can see very clearly again the external resorption. So as always, it's always the same: 3-dimensional X-ray, digital scan, implant planning, producing the temporary on the same day, and then we're ready for the implantation. And you can see the implant should always be placed a little bit more palatally, just to reduce that recession risk to 70%. As we said, if you place it too far to this side, to the label side or to the buccal side, the recession risk just increases so drastically to almost 60%. So this is the implant placement in the 3-dimensional X-ray. This is then the tooth removed, and you can see the guide in place with the guide sleeve. This is where the drills go through and guide for the implant position. And this is then the implant placed. You can see the perfect alignment of the implant notches with the guide sleeve notches, so that's absolutely perfect. And this is then the temporary. It's all still 1 day, the temporary placed together with the bone augmentation. And this here is the gum graft looking out of the gum. This gives us just a bit more stability and a bit more meat, so to speak, which can result. Because we remember, whatever happens the first 3 years, you will lose 1 millimeter. This is then the X-ray directly after the operation. You can see we're in the comfort zone. This is the enamel margin of the neighboring tooth. This is roughly the enamel margin of the other tooth. So we are right 2-3 millimeters between the enamel margin of the other teeth and this one, and perfectly level with the bone. This is the temporary then after 6 weeks, and this is the final result. So if we compare now before and after, you can see the patient wanted to have this tooth a little bit darker. He wanted us to replace exactly the same situation he had. That's exactly what we managed. We improved the gum situation a little bit, but remember, we will lose probably 0.5 to 1 millimeter over the next 3 years. So probably we will end up in a few years exactly with the same situation we had here. So thank you very much in this case to Gianluigi Milizza, who has done the dental technician work. And of course the planning and the guides were done by Mr. George Leventi from Aeon Dental Designs. They're both outstanding technicians, and without them, and of course without my nurse and AJ, Rebecca and AJ, I wouldn't be able to do this case. But I'll show you later the team around this success. So this is then the final X-ray, platform switched restoration, platform switched abutment, and then absolutely stable bone. You can see the bone actually starting to grow over that. So that should be a stable situation for a long, long time. I think we're coming now to the last case, or a few last cases. You can see this procedure becomes just very predictable. Same thing again, the broken tooth, the 3-dimensional X-ray, digital scan, take the color, prepare for the operation, and then you can see the before situation and the final situation. And that means we can replace teeth now, and we can actually be as good as nature. In some cases, maybe even a bit better. We cannot just do that for front teeth, we can do that for posterior teeth as well, as a standard option. You can see, sorry it's a bit German, it was for a German lecture. You can see the before here, and the patient had here a external resorption, and this is then the placement of the crown, perfect bone level. And you can see, just compare the before, sorry the pictures have a little bit of Hu values, a little bit before and after, gum situation, everything absolutely perfect. So we can replace nature now, like for like. So this is my last case, I think, for today. Beautiful lady, beautiful teeth. Unfortunately, a phone was thrown at her. So this is a picture from her in the first moment of shock, so the quality is not perfect. I apologize for that. But she lost, you can see she cracked her teeth due to the impact of the phone, and that was the situation she presented herself with. And now, of course, you see the lady has shown all her gums, a beautiful smile, and now we have to prove that with modern implantology we can actually recreate nature and give somebody back their confidence and their smile. This is the x-ray here. The endodontist has done a fantastic job excuse me, in trying to save those teeth. But of course the fractures were very deep, so we had to extract the teeth after discussing the options like orthodontic extrusion or dentures or bridges. She wanted to go for implants, and that's what we did. So we planned for immediate implants. And you can see here the crack of the tooth quite a long way down. So I think, despite the young age, she was I think nearly 30, still I think the best option. Same again, you know the procedure now, precise planning with the 3D x-ray and digital scan, then the precise implant planning, and then gum grafts, in this case on few occasions, lifting the gum again into the position. And this is how it looks like a week later, and this will heal just wonderfully. And you can see the gums really strong on our implant here on this side, and she wanted to level the gums here a little bit, and this will grow even further and get us a better result. Unfortunately, she complained further about pain, and something must have happened because the other tooth now started to be a problem, the right central incisor. So we decided to place an implant here as well. So same again, 3-dimensional x-ray, digital scan, implant planning, here the wax up, implant position planning, and 2 implants right next to others, always very tricky to have a good aesthetic result. So we needed to be perfect, and you can see here very, very thin fracture, but all the way entertaining inflammation. Root canal treatment well done, a little bit too long, but not a big problem. And this is then the temporary, slightly different colors, but in the end not war deciding. And wonderful situation, you can see the implant almost at the same level. And then taking the color is very important, not just taking the color which it is, but also taking the color which it is not, so the technician can see the differences, and not just taking it with a normal camera, but also with the polarization filter. That means removing the reflections of the teeth. Then the implant scan, and then the production. You can see here now the difference, the production of the individual crowns. So you have the titanium screw, the titanium link abutment, and then an absolutely wonderful full ceramic crowns. Kudos again to Mr. Gianluigi Milizza for such a wonderful work. This is then the soft tissue situation. You can see absolutely beautiful stippling. That means the connective tissue, the fibroblast, starting to pull. The stippling, absolutely wonderful. And then the situation here, again a wonderfully shaped emergence profile just because of the temporaries here. You can see on this side, on the right side from here, so the upper left central incisor, you can see much more mature tissue. You can see the resorption here. It's a difference of around 0.5 to 1 millimeter. This will resorb until here roughly as well, but overall an absolute stable situation, and this will remain stable for a long time. So these are the implants in place, and then we are ready for the final crowns. And this is the final crowns directly after placement. You can still see a little bit sulcus separation, just did a small composite filling, and instead of a veneer. And sorry, that's the before picture, and that's directly at the placement. So I think we have reached a quite good situation, a quite good smile. And that's the situation a few weeks later. So absolutely healthy tissue, and you can see that these are actually implants and not her own teeth. So she didn't brush perfectly well, unfortunately, so you can see here, I would have loved her to clean that a bit better, maybe just a bit careful, but the gums nonetheless look very healthy, and I think her smile shows that she's confident again to smile properly. So an absolute great thank you to Mr. Gianluigi Milizza, and of course on the left is Mr. George Leventi from Aeon Dental Designs. So both of them fantastically gifted technicians, each with their strength, and without both of them these treatments would absolutely not be possible. And of course, a great thank you to my team, of course to Rebecca, to AJ, and to Diana, who accompanied these cases. So thank you very, very much for your time. I appreciate you watching the video till the very end, and I hope that you enjoyed it. Thank you so very much.